Hello, welcome to AMCI Saturday Study Session, or SSS. I'm Mrs. J, Curriculum Director here at AMCI, and I am delighted to present AMCI Lead Instructor Ms. Tamika along with her guest. Without further ado, let's get started. Take it away, Ms. Tamika.
Hello, everyone. Happy Saturday. How is everyone doing? Talk to me in the chat. Let's see who's all here of today's study session. But I'm so glad you guys are all here. But first off, I want to introduce the wonderful team to you. I'm Mrs. Tracy, and I'm just here actually to introduce you to your wonderful lead instructor for our Saturday study session, and that's going to be Miss Tamika. Hi, Miss Tamika. How are you?
Hello, Miss Tracy. I am well. Good morning, coders. It is my pleasure to be here with you guys. When I was studying for the exam, oh my goodness, this was like my bread and butter. I loved group study. So my hope is that you guys will find it just as beneficial, and I know you will, because Miss Tracy and Miss Rochelle have put together a whole lot of good material, and I have delved in and just really immersed myself, and I'm hoping that you guys will find it very beneficial. I know you will. You got to pass. And Miss Tracy, they're ready. They're
I
ready. I know it.
it's what?
All right. We are ready to warm up, and no, each question is not timed individually. You have a set amount of time in order to complete the exam, and so AMCI has been very strategic in actually working it out that you shouldn't spend any more than 2 to 2.5 minutes for each of the scenarios in order for you to complete the exam. Okay. All right, so we are ready to go. Everybody is ready to stretch their muscles and work out their brain. So here's our first scenario, and I'm gonna have Miss Tracy gonna read for me. Thank you, Miss Tracy.
You're welcome, Miss Mika. All right, here we go, coders. Our answers are A, 11057, D23.5, D23.4, B, 11200, 11201, modifier 51 times 5, D23.5, D23.4, C, 11200, 11201 times 4, 11201, modifier 52, L91.8, or D, 11200, 11201 times 5, L91.8. The patient is here to see us about some skin tags on her neck and both underarms. She has had these lesions for some time. They are irritated by her clothing, itch, and at times have a burning sensation to them. We discussed treatment options along with risks. Informed consent was obtained and we proceeded. We removed 16 skin tags from the right axilla, 16 tags from the left axilla, 10 from the right side of the neck, and 17 from the left side of the neck. What CPT and ICD-10 codes are reported? All right, coders, I'm going to give you 2.5 minutes, and your time begins now. Good luck. Oops. Okay, that is time, coders. Get your answers in the chat.
I see lots of good answers coming in there, Miss Tracy. What do you think?
I see it.
I see it, guys. All right, so I think we are slowing down with some answers. I wanted to give everybody a chance to pop those answers in there, and I was responding to some of you, but hey, we need to go ahead and solve this thing, as many of you have. Some of you are very close, and we're going to show you just how close you are so we can nudge you on over. Okay, here we go. We're going to unpack it here and look at some keywords. So this patient is here to see us about some skin tags. They are on her neck and both underarms. 16 skin tags were removed from the right axilla, 16 from the left axilla as well, 10 from the right side of the neck, and 17 from the left side of the neck. Okay, so your answer is D. And many of you got that. And I saw some folks catching themselves because C was a strong contender. But as soon as you see skin tags, okay, you think, let me head on and start counting, okay? So we have right axilla, we have the 16, the left axilla, 16 as well. The right neck, we have 10, the left neck, 17, for a total of 59 skin tags. So how do we account for all of them? Well, we're going to take a look first at code 11057. As Ms. Tracy would say, this is our outlier, and it is coding for a benign hyperkeratotic lesion. We don't have any mention of that. We, in fact, are looking for skin tags, and we already know that if the common language of the parent is wrong, you already know that its dependents, they're going to be wrong also. So these are little things that can buy you just a few seconds here and there. If the language is incorrect on this parent code for the common language, remember that's anything prior to this semicolon, and the common language, if the language is incorrect, then anything that falls under it as a dependent, it's going to be incorrect as well. Okay, so code 11057, that's no longer, it's not a contender. Okay, so again, we're looking for skin tags, and so that one's off the table. So let's take a look at 11200. So we already know that this has to be in the mix. It's in all three of our answers, but let's determine what separates B, C, and D. So for 11200, indeed, it is the removal of skin tags up to and including 15 lesions. Well, we have 59. What is a coder to do? All right, we got to hop on down to this add-on code for 11201. How do we use it? Well, we know with this modifier 51, I already took it off. We already took it off the table. We don't need the modifier 51 there. Okay, so we're going to take 51 off because we don't need it with multiple procedures. Everything we need is in the code language. Okay, so that one won't do. The 51 with the times 5. So we're going to head on down and take a look at what does it mean if we have 11201 times 4. All right, so each additional 10 lesions or part thereof, that language there is very, very important. Okay, so we have 44 more we need. In this answer C, we have 15 plus 40, we have 55 indeed that we're coding for, because the 10 times 4 would be 40, and then the 15 that we already have. But in fact, we still need to code for 4 more lesions. Okay, so you see they tried to solve it with 1120152 with reduced services. No, we're not doing that. It's part thereof, so we need to code 1 more. All right, so if it says part thereof, it means anything from 1 through 10 you're accounted for with that. Okay, it doesn't matter if it's 1 more, we still have got to do another multiplier. So we see here 15, we have to do that times 5. That would give us 50, and that would be 65. Doesn't matter that we have 59, that part thereof, that's the deciding factor. Okay, so can't use that 52. We don't need it with that. We're going to take it off the table. And in fact, D is your answer. All right, so we'll take a look at the L91.8. All right, for that one, it is coding for other hypertrophic disorders of the skin. And so we are in the right spot there. And that is your code. All right, so I think everybody's doing good. Okay, let's see. Is everybody, I think everybody, whoop, whoop. Okay, I'm glad everybody is hanging in there and doing what you need to do. So we're going to keep on going because, hey, we got time to keep, right? We're going to go on with the next one. And Miss Sarah, let's do it, lady. Go ahead and read to these coders. Thank you.
All righty. Hi, coders. Okay, we have A 15758, B 14301, C 14301, 11606 with modifier 51, and D 15738, 11606 with modifier 51. A 45-year-old male with a previous biopsy positive for malignant melanoma presents for definitive excision of the lesion. After induction of general anesthesia, the patient is placed supine on the OR table, the left knee prepped and draped in the usual sterile fashion. IV antibiotics are given. Patient had previous MRSA infection. The previous excisional biopsy site on the left knee measured approximately 4 centimeters and was widely eclipsed with a 1.5 centimeter margin. The excision was taken down to the underlying patellar fascia. Homeostasis was achieved via electrocautery. The resulting defect was 11 centimeters by 5 centimeters. Wide advancement flaps were created inferiorly and superiorly using electrocautery. The allowed skin tags to come together without tension. The wound was closed using interrupted 2O monocryl and 2 retention sutures were placed using number 1 Prolene. Skin was closed with a stapler. What CPT codes or code is used and reported? And you have 2.5 minutes, coders, starting now. All right, that's time, coders.
Thank you, Miss Sarah. All right, coders, I want to give you guys time to get your answers in there. You guys are working hard. I know you are. I see it. I see it. I see it. All right, we're going to start going over this one. You still got some time. Yeah, there they go. All right, so we're going to jump right in. You know the first thing we're going to do, we're going to take a look at some keywords. Those keywords will help point us in the right direction. They always do. All righty, so we have got a 45-year-old male. All right, biopsy positive, malignant melanoma, excision of a lesion, left knee, excisional biopsy site of the left knee, approximately 4 centimeters, 1.5 centimeter margin, an excision, all right, taken down to the underlying patellar fascia. Then we have a defect of 11 by 5 centimeters. Wide advancement flaps. Okay, that's key right there. I mean, like, that's key. All righty, your answer is B. All right, and we're going to unpack why. Okay, so we have for 15733. All right, that's coding for muscle myocutaneous or fasciocutaneous flap. All right, and so that makes code 15738 of the lower extremity. That's not correct because, yes, we need the lower extremity, but not associated with the muscle myocutaneous or fasciocutaneous flap. Remember what I said before? If this common language, and that's the language that is before this semicolon, if it's incorrect, any dependent that falls below it is going to be incorrect as well. Okay, so save yourself some time. As soon as you hit this and you see that this is a dependent of that, take it off of the list. All right, so that's in fact what we're going to do is take that one off the list. 15738, it is gone. All right, let's take a look at code 15758. Again, Mrs. Tracy likes to call them our outliers. All right, why is it? It's coding for a free fascial flap. Nope, we don't need that one. All right, so we're going to take it away. And I'm going to answer your question about that margin in 1 second. All right, so here we go. That one is gone. Now, as soon as you see advancement flap, remember you have some key terms that will help to guide you. You've got to start thinking ATT. Okay, start thinking ATT. And I know you guys have your books chunned, and you've got to have all of your FTRs, okay, on that specific page, because then it'll help to guide you. Okay, so in fact, we're going to take a look at 14301. It is an ATT, or an adjacent tissue transfer, okay, or rearrangement, any area. All right, and the defect to any area. Okay, there we go. FTRs right here already. Advancement flap. Boom, there you have it. Anytime you see any of these keywords, that's why you want these FTRs on the proper page, but kind of start committing some little things to your memory. If you see ATT anywhere in there, you got to start thinking, is this an adjacent tissue transfer? Okay, so the defect, 3.1 square centimeters to 60 square centimeters. Well, in fact, this ATT size is 11 by 5, which is 55 centimeters. Okay, so already we know we are right where we need to be. It falls within that range. Okay, so we're good there. Now, these two, what is the determining factor? This code here, 11606 with the 51 modifier. All right, all well and good, but, and we know it's coding for a malignant lesion, but what is the key with the ATT? All right, we know what that is. Like I said, because of that, it is an excision of a malignant lesion, but with an ATT, that excision is bundled. So even though we have these margins and all of that stuff, we don't need to worry with that here because that excision is bundled. So the only thing you are focusing on is the defect once you know it's an ATT. Okay, so that one's gone. And 14301 is in fact your code. So you see all of these things. It's important to read through and grab all of these things, but there's certain keywords that when you grab them, you need to follow, like follow that lead. And once you realize that, hey, this is an AT&T, you're not worried about the size of that lesion, but what you are looking at is this defect. Okay, and you know that excision is taken care of, it's bundled. Okay, and that'll lead you right to where you need to be. Okay, all right, that specific FTR, if you have your TTT manual, then you have everything you need in there. Okay, and Mrs. J goes over it beautifully with all of the lectures that lead up to it as well. She'll guide you right along so you'll know where to put it and how to use it. Okay, so everybody, I think is, yeah, I see some, I got it. Yes, bundle, 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 bundled, baby. All right, that is it for me. Miss Tracy's gonna come and share some more scenarios with you guys. I'll talk to you in a bit.
Thank you so much, Ms. Tamika. All right, coders, are you all warmed up? Sorry, my alarm's going off. Are you guys all warmed up? Let me know in the chat. How's everyone feeling? Great job, Ms. Tamika. Thank you so much. Those were wonderful scenarios. Okay, so let's go ahead and, oops, actually, sorry, give me 1 second. I want to back up one slide. Okay, here we go. All right, so let's go ahead real quickly. We do have some more scenarios for you, but I do want to go over our keyword concept as well as our steps to solving a board exam scenario. So let's start with our keyword concept. So your keyword concept answers the following: who, what, when, where, and how. This is what you should be pulling out of each scenario and typing in the chat, okay? Really, just practicing keyword concept is going to help you become so much better. If you're able to pull out these 5 things, you're going to see on our next scenario how that's really going to help you as well, okay? So let's go ahead and review these. So who is doing the procedure, the name of the title of the physician, and know who you're coding for. So you want to just kind of hone in on who you're coding for. That's really, really important, and the name or the title of the physician, okay? Also, who is receiving the treatment. So I always tell you guys in class, you don't have to worry about the patient's name, but definitely always get in the habit of highlighting or pulling out that keyword for the age, okay? It's really important as some of those codes are age driven, and or the gender. What we know, this is important, of course, it goes without saying. We need to know what the diagnosis as well as the procedure is. So those are your major keywords there. When answers when in time the procedure or service was rendered or performed. So is this an initial, a subsequent, a secondary, 6 months ago, redo? Those are some really, really important keywords. So if you see those in your scenario, pull them out. The location is really important. You have to know where on the body this procedure is being performed. Where was the procedure performed? Is it an outpatient or inpatient facility? Don't have to worry about that so much right here in this class, because all of these are going to be outpatient. And how was it performed, approached, or the position of the patient? So here's some keywords to look out for: percutaneous, open, closed, supine. Look for words laparoscopic procedures, prone, just the position of the patient and things like that, okay? All right, and let's review real quickly on how to solve a scenario for the coding exams. And these are, of course, multiple choice questions because the CPC board exam is 150 and it's all 150 questions and they're all multiple choice. So the reason why we read our answers first is because we want you to just kind of get in the habit of looking at those answers first, and it kind of will help you to approach that scenario a little bit better. You want to look for things like modifiers. If you have some modifiers on your codes, look at those diagnosis and procedure codes and which answers share the same codes. Sometimes A, B, and C may have the same first listed code, and D, as Ms. Tamika said, the outlier or the oddball will be the something that's different. So just kind of look at the similarities and the differences between those codes and which answers share the same codes. Also look at how the codes are sequenced. That's really important. That's something you will definitely be tested on the exam is your sequencing. So if you see a simple repair sequence before a more complex one, we know that would be incorrect, okay? And you can go ahead and eliminate that immediately. And find your keywords in the scenario. So we just went over the keywords. That's your step 2. Step 3, use your chun. It's really important to chun your manual and use that chun. Pay attention to your notations at the top of the page, the bottom of the page, those FTRs, and anything that you put at the code level. And also read those parenthetical guidelines and again, eliminate all wrong answers immediately. Step 4, you want to determine the differences in the remaining codes. And we do not code preoperative diagnosis in the setting of a postoperative diagnosis. Also, we do not code things that are not confirmed by the doctor. If he didn't say it, it didn't happen, or products that the physician used for closures. Most closures are bundled. Professional coding, just remember CPT codes take precedence over ICD-10 CM codes, and for facility coding, ICD-10 codes will have precedence over the CPT codes. So the purpose of this class, and because you all are going to be taking the CPC, that's professional coding. So the money drivers for professional coders are those CPT codes. I know sometimes because we came from part 2, you can get in the habit of just trying to choose your codes choose your answer based off of the ICD-10 codes. Don't do that, okay? I see some of you today trying to make your code selection based off of that. Definitely look up those procedure codes first. And then if you have to, I call it the tiebreaker, then you go to your ICD-10 codes. But sometimes you can just solve that scenario just based on just the CPT codes without having to go to ICD-10, and that's what you want to get in the habit of doing, okay? Those CPT codes, like I said, are the money drivers for the professional coders, okay? And that's what you guys are going for, and I think that's it. So are we ready to do another scenario? Let me just type in the chat, or let me just look in the chat and see what you guys are typing. They are paper. Oh, I see someone answered you already. But just in case y'all are wondering, the CPC exam is a paper exam. But I will say now with COVID-19, they are allowing some people to take the exam. I know I've seen some people out there saying they've already taken the exam at home, and AAPC is actually allowing that now. So it's kind of changing a little bit. So of course, in that aspect, it will be on the computer. Okay, so let's go ahead and move on to our next one. And can you read this one for us, please, Miss Sarah?
Yes, definitely. All right, we have A 19125 modifier RT, B 11400 modifier RT, C 19125 modifier RT, 19285, D 19120 modifier RT. A localization wire placement in the lower outer aspect of the right breast was performed by a radiologist the day prior to this procedure. During this operative session, the surgeon created an incision through the wire track, and the wire track was followed down to its entrance into the breast tissue. A nodule of breast tissue was noted immediately adjacent to the wire. This entire area was excised by sharp dissection, sent to pathology, and returned as a benign lesion. Bleeders were cauterized, and subcutaneous tissue was closed with a 3-0 Vicryl. Skin edges were approximated with 4-0 subcuticular structures, and adhesive strips were applied. The patient left the operating room in satisfactory condition. What is or are the correct codes for the surgeon's service? Then you have 2.5 minutes, coders. All right, that's time, coders.
Okay, thank you so much, Miss Sarah. Okay, so great answers coming in the chat here. Awesome. Well, you guys are reading forensically on this one. Okay, so let's go ahead and look at our answers. So it looks like A and C are the same, first listed code there. And I think we all can recognize B there from those from our class discussion and your discussion or listening to the lecture. 114 we know is a benign lesion, right? Excision of a benign lesion. So our answer is A, okay? See, a lot of you said that, so let's find out why. Okay, so let's go ahead first and go to the keywords. We have location, wire placement, right breast, radiologist, day prior, surgeon created incision, wire track, breast tissue, nodule, entire area, excised by sharp dissection, benign lesions. And look what it's saying. What is the correct code for the surgeon's services? So we are coding for the surgeon's services here. So that's why I'm saying it's important to know who you're coding for. So let's go ahead and look at this. All right, so there's some breast tissue and it's being excised, right? There it says there was an excision of a benign lesion on the breast. Okay, so that's what's happening here. And if we look at 11400, that is an excision of a benign lesion. However, that is excising the location on the trunk, arms, or legs. Okay, and again, this is a breast lesion, benign lesion. So we are going to get rid of that answer B because it is coding the wrong location. Okay. All right, so let's go to 19120. This is also incorrect because this is an excision of a cyst, fibroadenoma, or other benign or malignant tumor. And we need to find that excision of that benign breast lesion. So we're going to get rid of that one. That's the wrong procedure. Okay, next, we're going to look at 19125, and this is what we're looking for. Excision of breast lesion identified by preoperative placement of radiological marker, open single lesion. Okay, so I do like that code, okay, but we do have that in A and C, but we have that additional code in answer C. Okay, so we just have to see what that is. So let's go ahead and just place a star next to 19125, and I want to read what 19285 is saying. And that is for placement of breast localization device. Okay, so if you read the language above, it says the excision of the breast lesion identified by preoperative placement of a radiological marker. So going back up to our scenario, it says a localization wire placement in the lower outer aspect of the right breast was performed by a radiologist the day prior. Okay, so that was placed the day prior by the radiologist, and that's pretty much what it's saying in 19125, that this excision of the breast lesion was identified by a preoperative placement, which the radiologist did the day prior, right? So we're not going to code 19285 in addition to that 19125. That 19285 was performed by the radiologist, right? So we're going to go ahead and get rid of answer C, okay? And again, the surgeon services, going back to who it's asking us to code for, is going to be that 19125, okay? And we're going to pin that RT modifier just to indicate that it was the right breast, okay? All righty, coders. How do you feel about that one? Okay. Aha moment, that's great. Love seeing the aha moments. Okay, so let's go ahead and great job, coders. Let's move on. I have another one for you. And do you want to read this one for us, Miss Tamika?
Sure can. I'm right here, Miss Tracy. All right, coders, you guys are ready to roll. All right, we'll start off with our answers. A, 13152, 11642 with a 51 modifier. C, 44.311. B, 13152, 11442 with the 51 modifier. C, 44.311. C, 17313. 13152 with the 51 modifier, C, 44.119, and finally D, 17311, 13152 with the 51 modifier, and C, 44.119. All right, we have an operative report with the diagnosis of basal cell carcinoma. The procedure is a Mohs microscopic excision of skin cancer tissue. The site is the face, left lateral canthus eyelid, the preoperative size of 0.8 centimeters. Indications for surgery is an area of high recurrence, area of functional and or cosmetic importance. Discuss the procedure, including alternative therapy, expectations, complications, and the possibility of a larger or deeper defect than expected, requiring significant reconstruction. The patient's questions were answered. Local anesthesia, 1:1 Marcaine and 1% lidocaine with epinephrine, sterile prep and drape. Stage 1. The clinically apparent lesion was marked out with a small rim of normal appearing and excised down to subcutaneous fat level with a defect size of 1.2 centimeters. Homostasis was obtained and a pressure bandage placed. The tissue was sent for slide preparation. Review of the slides showed clear margins for the site. Repair, complex repair. Repair of Mohs microscopic surgical defect. Wound margins were extensively undermined in order to mobilize tissue for closure. Homostasis was achieved. Repaired length 3.4 centimeters. A layered closure was performed. Multiple buried absorbable sutures were placed to reoppose deep fat. The epidermis and dermis were reopposed using monofilament sutures. There were no complications. The patient tolerated the procedure well. Post-procedure expectations, including discomfort management. Wound care and activity restrictions were reviewed. Written instructions with urgent contact numbers given, follow-up visit, and suture removal in 3 to 5 days. What CPT and ICD-10 CM codes are reported. All right, coders, you have 2.5 minutes and your time, it starts now. All right, coders, that is time, and I see you guys are on fire in that chat, and they are ready to hear the explanation, and I think most of them know what's up, Miss Tracy.
I agree, Miss Tamika. I think they all know what's up because it looks like we have, I won't say 100%, but I want to say we have close to 100% here. So that's awesome. So really, coders, the ones who didn't get this correct, that's okay. You're going to quickly spot your mistake. And really, keywords, 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 okay? Follow those keywords. So the main keyword here, what is our main keyword? What would you all say is our biggest keyword that we would follow in this scenario? That's right, Daryl. Yes, Meredith, you got it. Fatima, Aisha, Michelle. So what kind of procedure was going on here? Okay, well, let's look. So our keywords, we have basal cell carcinoma. What's our procedure? This is a Mohs surgery right here, okay? So that's a big hint. Face left lateral canthus eyelid, stage 1. Remember, those Mohs are in stages. Lesion, excised subcutaneous fat, 1.2 centimeters. Repair, so there's a repair here, complex. We have a repair, Mohs micrographic, surgical defect. Closure, repair, 3.4 centimeters. Layered closure. Okay, so here we go. Answer D. That is going to be the answer, okay? And let's find out why. And again, I didn't look at my answers first here, but looking at my answers, I'm seeing a lot of stuff from these answers, okay? Now, if I look at the second listed codes in A and B, I recognize those right away. Those are some most easily recognizable codes once you code these a lot. So 116 we know is malignant, 114 is benign, right? And then A and B are for closures in the first listed code there. And then it looks like C and D, I recognize those as Mohs surgery. So did you guys recognize those as well? I think the more you practice these, the more those codes will start to kind of pop out to you. Okay, so let's first look at that 13152, okay? So 13151 is the parent code there, and that reads repair of complex repair of eyelids, nose, ears, and or lips, and that gives a size of 2.6 to 7.5 at the 13152 level. Okay, so oops, sorry, there we go. So that checks out. We did have a complex repair here. The length is 3.4 centimeters, okay? So that does check out, and this is of the eyelids, okay? You notice up there, the site is the face, and it says left lateral canthus eyelid, okay? So I do like that 13152, which is good because look, it's in all of our answers here, okay? So let's move on. We're going to put a star there, and we're going to move on to the next codes, okay? So 116, we know that is a malignant excision, as it says there on the page, okay? And this is we're not going to be coding this as a malignant excision because this is a Mohs micrographic excision. So it's being very specific on the type of procedure here, and we are not going to code this as a malignant excision, okay? And we're also not going to code this as a benign excision, okay? Because again, we need that Mohs micrographic code, okay? So those are both the wrong procedure. Moving on to our Mohs codes here. And that's pretty much, if you have this section chunned well, just as you watched in the lecture with Mrs. J, and as you know, we practiced in class, if you have these locations, we know that 17311 and 17313 code family are basically Mohs surgery based off of whatever the location is. So if you have your locations listed right next to those codes, it would be easy to kind of narrow down what our answer is, right? So if we look at 17313, of course, that's for Mohs, and the area, the body location is trunk, arms, or legs, okay? We're looking for the eyelid. So that's not going to cut it there, okay? So we're going to get rid of answer C. And if we look at 17311, this is coding Mohs again, and it is coding for the head, neck, hands, feet, genitalia, and so on. But the eyelid, that would be that's right there, and it gets coded in the head, okay? The head location. Alrighty, and that's good. That's the first stage. We know that it says stage 1 up there, so there was only one stage, so we only have to code that 17311. Then we're going to code that 13152 for the complex repair. And then finally, like I said, we always look up those CPT codes first. And we didn't even have to go to our ICD-10 to look up that C code, but if we do look that up, it is C44.119, which is basal cell carcinoma of skin of left eyelid, including canthus. And that checks out, okay? So there we go, coders. D is the correct answer. All right. But I think you guys rock that one. So just follow those keywords, really following those keywords, you know, that's where it's at. So, and type your keywords in the chat here. It will be so helpful. You'll see that as you go along. Okay, so I'm going to hand this back over to you, Miss Tamika.
Thank you, Miss Tracy. All right, coders, I think you guys are doing outstanding. And I see someone was saying, oh man, I didn't think about the moles that was, you know, substantial there. You want to consider when it is moles, the layers are included with the actual procedure. The surgeon continues to remove layers until he or she doesn't see any more cancer. So you're accounting for what's happening with that lesion in the Mohs procedure. Okay, each time the surgeon goes through a different stage, they're removing layers. Okay, so you just don't overthink it though, because all you want to do is when you see the Mohs, you got to consider, okay, is this what I'm working with? Okay, they're not trying to trick you on the exam. They just want to know you can read forensically and you know those guidelines, and you guys have a superpower. You're going to have those FTRs on the page. Okay. All right. So here we go. We're going to do one more in INTEG, and then we're going to roll over into musculoskeletal. Okay. So Miss Sarah, if you will read to these wonderful coders, I sure appreciate you, lady.
Oh, yes, definitely. Okay, we have A 11900, J3300, L90.5, B 11900, J3301, L91.0, C 11951, J3300, L91.0, D 11950, J3301, L90.5. The patient is here to follow up for a keloid excised from his neck in November of last year. He believes it is coming back. He does have a recurrence of the keloid on the superior portion of the scar. Because the keloid is still small, options of an injection or radiation to the area were discussed. It was agreed our next course should be a Kenalog injection. Risks associated with the procedure were discussed with the patient. Informed consent was obtained. The area was infiltrated with 1.5 cc of medication. This was a mixture of 1 cc of Kenalog 10 and 0.5 cc of 1% lidocaine with epinephrine. He tolerated the procedure well. What codes are reported? In 2.5 minutes on this one, coders, you've got this. And that's time, coders.
Thank you, lady. I appreciate you, Miss Sarah. All right, coders. I see you guys are getting your answers in there in the chat. So I wanted to allow you guys time to slide on into home plate. And I'm going to say safe. I see a lot of good stuff going on. So let's go ahead and unpack it here. All right. You know what we're going to do? We're going to zero in on some keywords to help guide us along. Okay. This is a follow-up. It is a keloid excised from the patient's neck. There's been a recurrence of the keloid, and they're going to receive a Kenalog injection, 1 cc of Kenalog 10, okay, 0.5 cc's of 1%, lidocaine with epinephrine. So I'm going to take a look here at code 11900. Indeed, this is a good code because it is speaking to the fact of it being an injection intralesional. Okay, now I know you guys know from midterm, you know I got to ask you, what does intralesional mean? I know you know. Don't let me down. I know you won't. I know you won't. There we go. Yes, I see you, Meredith. Yes, it means into the lesion. Okay, in fact, that's where that injection needs to go. Yes, Aisha, I see you guys. You are correct with that. So now that we know what we need to do to this lesion, we're going to take a look at these other codes. All right, let's see what 11950 and 11951 actually means to us today. Okay, so we have this is subcutaneous injection of a filling material. It's wrong on so many levels. We already know this is intralesional. It's not subcutaneous. We already know that's underneath, right? Okay. So, and no mention of any filling material. In fact, this patient is getting a Kenalog injection. So we can go ahead and just immediately take those off. Okay. So it's a good idea to, when you can take something off immediately, you've already looked at this, that looks good, check these out real quick. Once you see that, boom, it's out of there. Remember what I told you earlier. If this common code language, anything before that semicolon, if it is incorrect, if that parent is wrong, this dependent is gone. It's gone. Again, if this common language is incorrect, okay? So if that's wrong, then the dependent is wrong as well. So immediately we can take it off. All right, so now we know this is good. Now we need to take a look and see, what are we coding for right here? We're in fact coding for what is used for the injection. So code J3300, it is an injection of triamcinolone acetonate aconide, and it's triamcinolone aconide preservative free. Okay, but J3301, that is a better fit because it is an injection of triamcinolone acetonide, but one of the, what you would say the trade name you would see would be Kenalog or triamcinolone. Okay, so that's going to be what we need there. And indeed, it is 10 milligrams. Okay, and we have Kenalog 10. So all we needed right there, Kenalog, and we look here for the scars for L90.5 and L91.0, that's indeed the keloid scar. So we know that that's correct. So we could already take this one off once we notice that the injection isn't quite what we need. Also, it's coding for 1 milligram. And so that wouldn't be correct anyway because we're not coding for enough. But this one here, that fits the bill. 10 milligrams, it is indeed Kenalog. And so that is our code. And again, like Ms. Tracy said, we really don't fool too much with the ICD-10 codes when we are coding on this exam because it is a matter of time and we only default to these if we need to break a tie. And in this case, we already knew what we needed once we verified this drug. Okay, so different ways to help you shave off time because like we've talked about earlier, the CPT codes are going to drive the money for a pro-fee coder. Okay, so once we know that these are correct, then they just kind of fall in line unless you need to break a tie. Okay, so is everybody good? I see some ahas. I saw one, oh no, but hey, you're good. Okay, so it's going to tell you in your scenario, whether or not you know that it's not subcutaneous because it's not saying anything about it being subcutaneous in here. And also it's telling you that you are going to, where is it? You're going to inject. So another thing you can look at is injection. Okay. And you see subcutaneous, but it's not saying anything about a filling material. So again, you want to follow along with your words, your keywords that you're seeing. Okay. So if you're not seeing certain language in the scenario, then it's not going to apply to the code. Okay. So this, it's an injection. You see injection. We don't see anything about a subcutaneous injection. Also, this mentions an intralesional injection. We know we're dealing with a lesion because it is indeed a keloid, but nothing about a filling material or a subcutaneous injection. Okay. All right. So we're going to move on now to jumping into some musculoskeletal stuff. Okay. So give me 1 second and we will take a look at some additional codes. And I know you guys are ready, and I'm ready to see what you got. Because I think that you guys have done a tremendous job with coding a lot of the things that we had on tap for you today. I'm impressed. You guys never cease to amaze me. So let me get it going here. Hold on 1 quick second. Let's come out of this last one here. One All right, coders, I'm still here. Take 1 quick second for me, stretch your legs, and I'll be right Thank you for letting me know that, Aisha. I'm just chitting and chatting and chitting and chatting. I'm gonna get Miss Sarah that she didn't say, I don't hear you. I appreciate you, Miss Aisha. All right, I've been chitting and chatting, telling you guys, hang tight, and okay, now I'm back. All right, so now, as you guys can see from the screen, I'm back. All right, I'm not gonna time this one. I just want you guys to tell me what is the acromium, okay? So, and then we'll jump into some scenarios. All right. Miss Sarah said she thought I was still getting things ready. I appreciate you, Miss Sarah. See, that's what a true team member will do. It's just like she got it, she got it. All right, guys, I got it now. All right, I've got two screen goings, and I was telling you guys, I tell you, the integumentary system, it was not going down without a fight. It was still trying to steal the show. All right, so I see lots of great answers coming in, and in fact, the acromion is D. It is an extension of the scapula. So, wanted to just point that out to you guys. We have the acromion here, and you see, like when you touch up on your shoulder, that little knot that you feel, that's your acromion, okay? And you see these ligaments that are attaching it, in fact, here to the scapula. And you see the scapula comes up here, and indeed it is an extension of both the acromion as well as the clavicle. Okay, so that's just a little bit of really anatomy for you, okay? All righty, so you guys are ready to roll, right? Your injections would come from your HCPCS manual. Okay, and you are allowed to have your HCPCS manual when you go in for your exam. Okay, so that's where you would get your injections from. All right, so in fact, that is D. And now we're going to get into some scenarios. All right, Miss Sarah. All right, that's my partner right there. I'm tagging her in. She's got my back. It's your turn,
But I
lady.
tried. All right, we have A 20552, B 20553, C 20610, D 20553 times 3. A 39-year-old involved in a motor vehicle accident, MVA, a year ago arrives to the pain clinic with complaints of neck and left-sided radiopathy complicated by cervical degenerative disc disease. NSAIDs and physical therapy have been unsuccessful, and the patient requires multiple trigger point injections. The left multifidus trapezes and the right levitator scapular were injected. The area was cleansed and bandaged applied. Which procedure codes best describe this encounter? And you have 2.5 minutes, coders. And that's time, coders.
Thank you so much, Miss Sarah. All right, you guys, hey, I am calling 911. Y'all are on fire. I love it, love it, love it. All right. Hey, you guys already know what's up. I'm going to talk about it anyway. We got some folks that are real close, and once you see it, when I start explaining it, you're going to go, what? I knew that. I knew that. All right, so let's hit them with the keywords. All right, the answer is, in fact, B. Here we go. All right, this is a 39-year-old involved in an MVA, neck pain, left-sided radiculopathy, complicated by cervical degenerative disc disease. All right, multiple trigger point injections to the left multifidus and the trapezius and the right levator scapula were injected. Okay, so let's take a look. One thing I like to do is start noticing like those first three numbers. That lets you know that those codes are in fact really close together and at times, most of the time, a code family. And then we have the 20610. Okay, so we're going to take a look here, and yes, they were injected, multiple trigger point injections, so we know that that's going to drive us. Here we have our FTR, and you notice that if you have that down on the pages that are specific for these codes, this helps to guide you along, okay? And the key thing that you want to notice here is, are we coding for muscles or joints, okay? And it's not coded according to the number of injections. So we're going to start with this outlier of 20610. It is in fact arthrocentesis, aspiration, and or an injection, okay, but it's into a major joint or bursa, okay? And in fact, what are we coding for, okay? What are we coding for? What did we say? What are these? The multifidus, the trapezius, the right levator scapula were injected. And if you don't know, you know you can go. That's what you got, that CPT and those nice little drawings and stuff in your book. You hear me turning the pages. I'm giving you the page number. Pages 116 to 117 lists your musculoskeletal, your muscles, okay, from the anterior and the posterior part. I'm not going to say front and back because y'all are coders. You know what I mean. There we go. We mean the front and the back. It gives you the list of muscles. So this is for joint and bursa. We, in fact, are doing multiple trigger point injections on muscles, okay? So we're going to take 20610 off, all right? Now, in fact, we're talking about an injection, but we're talking about a specific type of injection, okay? So 20522. Now, remember I was telling you that there are times if the parent is wrong, then the dependents are. Well, in this case, it's just that particular code is wrong. But this parent, this language that we have here is some good stuff. It is an injection, single or multiple trigger points. That's what they're talking about in there. That's what they're talking about. But the only issue with that particular one, it's not coded according to the number of injections. We are looking for the number of muscles that are injected, okay? So in this case, we have 1, 2, and 3. So that 1 or 2, that's what's no good. But this parent language, that is good, okay? So we're going to pass on that first one of 20552. We're going to take him off. Now, let's focus on the dependent, okay? 20553, it is indeed an injection. It's single or multiple trigger points, okay? And with here, single or multiple trigger points, muscles, single or multiple trigger points, 3 or more muscles. What do we have here, coders? How many muscles are we coding for? 1, 2, 3. Yeah, I see you guys. There it is. There it is. There it is. Now, tell me something. Since it's 3 or more, now, if the code language does it for you, then we don't have to worry about, in this case, a multiplier because it's not saying each, it's saying 3 or more. So do we need this times 3? Do we need it, coders? And I think from your answers, you guys see that you don't. And for those of you who it slipped past you, yeah, then now you know, like, I got it. It got me that time, but it won't get me again. There you go. 3 or more muscles. So whether it's 3 or 5, this is your code for multiple trigger point injections into muscles. Okay, so we don't need that multiplier there. And so D, that's got to go. And 20553, that is your correct code. Okay. All right. How's everybody feeling? Everybody's okay? If you want to get a screenshot, you know how I would always tell you, you can get a screenshot if you need to, you may, before we move on. All right. In 5, 4, 3, 2, we got to keep on moving. All right, coders, here we go. Let's hit them with another one, Miss Sarah. I appreciate you reading for me, lady.
Well, of course. Here we go, coders. We have A, 23615LT, B, 23605LT, C, 23616LT, D, 23670LT. A 66-year-old sustained a left proximal humerus fracture. Standard deltopectoral approach was used and dissection was carried down to the fracture site. The fracture site was identified and fragments were mobilized and the humeral head fragments removed. Once this was done, the system was prepared up to a size 10. A trial reduction was carried out with the DePuy trial system and implant head. Sutures were placed in key positions for closure of the tuberocytes down to the shaft, including sutures through the shaft. The shaft was then prepared and cement was injected into the shaft. The implant was placed. Once the cement was hardened, the head was placed on Morse paper and reduced. A bone graft was placed around the area where the tuberocytes were being brought down. The tuberocytes were then tied down with a suture previously positioned. This gave excellent closure and coverage of the significant motion at the repair sites. The wound was thoroughly irrigated. The skin was closed with a vicryl over a drain and also staples in the epidermis. A sterile dressing and sling was applied. The patient was taken to recovery in stable condition. No immediate complications. What CPT code is reported? And you guys have 2.5 minutes, and I know you're going to rock it. All right, coders, that's time.
Thank you so much, Miss Sarah. I tell you, they got some answers coming in here. Yeah, this one you have to think about it a little bit. I'm gonna give you guys just a little bit longer because I see a few more answers coming in, and then we're going to go ahead and unpack this thing and see how we arrived at our answer. But I'm liking what I see, coders. What do you think, Miss Sarah? What do you think? I think they're flexing on us. They're flexing on us. We're in musculoskeletal. They are flexing. I see y'all in here. All right, so we're going to go ahead and see what we got going on. All right, so you guys know what we're going to start with. We're going to start with some keywords. In fact, the answer is A, and there's several of you who arrived at that answer, and some of you who didn't. I got a sneaky suspicion you're going to know what you kind of got off with, okay? All righty, so we're going to give you a little nudge, so we'll get you towards the right answer, all right? So we have a 66-year-old left proximal humeral fracture, the deltopectoral approach, dissection. All right, we have fragments that were mobilized, the humeral head fragments removed. We have a reduction, the Dupuytren trial stem and implant head, closure, tuberosities, a shaft, cement injected into the shaft. We have an implant that was placed, and then we have the head placed and reduced. We have a bone graft. Again, we have the tuberosities that were tied down. We got a lot going on in this scenario, okay? So we're going to focus in on here that we have a dissection that was carried down, and we have fragments that were identified and removed, okay? So we are dealing with a left proximal humerus fracture, all right? And once we know that a dissection has taken place, we kind of got a sneaky suspicion of what. Could it possibly be closed? Could it possibly be closed? Once you see incision, dissection, yeah, we know, hey, we got some cutting going on. All right, it indeed is not closed. So when we take a look at 23600, which is the parent, then we know that 23605, that's wrong, okay? We know it's not closed, okay? Because we got some dissection that has taken place, okay? Definitely open. That's right, Crystal, definitely open. All right, so we're going to move along. Let's take a look at 23670. It's open treatment, but it's coding for a shoulder dislocation. And in fact, we are dealing with the humerus. Okay, so open treatment, but we're in the wrong spot. So we're going to take off 23673, 23670. All right, so let's hone in on the next one. It's the humeral head. Okay, so we have 23615. All right, that is open treatment of the proximal humeral. Okay, there we go. Left proximal humerus. Okay, so with this particular code, we have that with fixation when performed, and we did have a whole lot of things going on with reducing and fixating the fracture, tying it down. We've got some tuberosities going on. So we have the complete reading of 23615, open treatment of proximal humeral head. That's good. Surgical or anatomical neck. We remember seeing about the neck in this as well. And it is a fracture. It includes the internal fixation when performed, and it includes repair of tuberosity or tuberosities when performed. Oh, that's some good stuff right there. That's some good stuff, okay? All right, now, although that's good, but we got one even better, okay? We got the repair included. What do we need? We got the tuberosities. We got that implant. All right, that's what okay, here we go. 23616, but that's for proximal humeral prosthetic replacement, okay? For it to be replaced would mean that they had one before. We have an implant that was placed, not replaced, okay? So that one's no good, and so the best we can do, we're going to take that one away. The best we can do is the 23615. That's accounting for everything else that took place with that. Okay, so we've got the open treatment, proximal humeral head, surgical or anatomical neck. We've got taking care of the fracture. We've taken care of the internal fixation when performed and a repair of the tuberosities when performed. Okay, so that is indeed our code. Okay, so yeah, yep, I know you start thinking, okay, replacing, your brain starts putting that's a placement, not okay, but it is a placement, but not a replacement. Okay, so you might want to highlight it or circle it in red just in case you see something along those lines. And again, your FTRs will help to guide you along as well. We already addressed what is the type of fracture treatment. It is indeed open, and we know that because there was some dissection going on. The type of treatment not related to the type of fracture. Okay, so we already addressed that. We know it's open, and the type of fracture, if it's not documented, it would be coded as closed. Okay, but we already know we've got a fracture and this person's been opened, okay, in order to address the issue. Okay, so we know the type of fracture is left proximal humerus fracture, and then not worried about any casting or anything. If they had a cast, and they probably got one with the hip replacement, it's bundled. Okay, so we've addressed everything we need. Okay, I know my brain does that too. You know, your brain will see stuff, you read it into place. All right, coders, I think you guys have had some aha moments. Okay, so we're going to keep on moving, and we're going to move into the next one. And Miss Sarah is going to go ahead and read us out. You guys got this one. All right, Miss Sarah.
All right, here we go, coders. We have A, 29805, B, 29806, C, 29807, and D, 29819. A patient is seen in the same day surgery unit for an arthroscopy to remove some loose bodies in the shoulder area. What CPT code is reported? And you have 2.5 minutes to rock this one. All right, that's time, coders, and you guys did outstanding.
Thank you so much, Miss Sarah. They have done outstanding, okay? And to address someone was saying, hey, what about that replacement? What I want to remind you of when you are solving scenarios, you want to choose the best code that you have available to you, okay? So that you guys don't get hung up when you're on the exam. You want to eliminate what you know is wrong, and then when you get it down to 2 or however many you have left, 2 or 3, you want to choose the best code, okay? So the ones that you know are wrong, take them off, and then what you're left with is going to be the best thing that you can choose based on that scenario, okay? So that way you don't get tangled up in, well, what about if you were real world coding when you're real world coding and Miss Sarah can't attest to it, then whoever you're coding for, they will let you know exactly how they want certain things done, okay? But right now we're focusing on this exam, so you're choosing the best answer from what you see, okay? All right, so we're gonna unpack this particular one. Let's get to some keywords. All right, D, and a lot of you have said D, and like Miss Sarah said, you guys have done amazing, simply outstanding. So here we go, coders. All right, let's take a look at some keywords. All right, so we're going to start. They were seen in the same day surgery. They had an arthroscopy to remove some loose bodies in the shoulder area. We're going to take a look at code 29805. It's an arthroscopy, but it is diagnostic, okay? So one key thing you want to take away when you are coding the scopes, you want to remember the difference between a diagnostic and a surgical scope. A diagnostic scope would only be when the provider or the surgeon in this case is taking a look around, okay? But as soon as they start to do something, as soon as they start to tinkering, then if they're doing something through that same scope, looking, and then they start to repair something or to remove something, it's no longer diagnostic, it would be surgical. And in fact, a diagnostic scope is always bundled. It's a part of the surgical scope, which is why you see separate procedure. Whenever you see that, then you know this particular code you would not use because it's oftentimes part of a more involved procedure, okay? So in this case, the surgeon is performing an arthroscope, but they're removing some loose bodies. So at this point, it would not be a diagnostic scope. It would be a surgical scope. So we're going to take away code 29805. All right. We're going to take a look at now code 29806. It's an arthroscopy, shoulder surgical. I'm liking that. I just said that's what we need. That's some good stuff. But here we go. This common language is good. But what follows that's specific for this code only, that didn't occur, okay? This capsulorrhaphy, that didn't happen in this case, and you guys caught it. A lot of you did, okay? And so we're going to take that particular one off. The 29807, repair of a slap lesion, nope. That didn't happen during this particular arthroscope of the shoulder, so that one is no good. We're going to take him off the 29807, and in fact, that leaves us with code 29819, and the full code would be arthroscopy, shoulder, surgical, with removal of loose body or foreign body, okay? That sounds good to me. In fact, arthroscopy, removal of loose body in the shoulder area, it is spot on. And so D with code 29819, that is your answer. I got a feeling you guys are feeling pretty good. And for some of you that just missed it just a little bit, I'm sure I'm seeing lots of, yeah, I got it. But most of you, you've got it, okay? So we're going to keep on rolling, and Miss Sarah's going to come on back and take us to our next scenario. Thank you, lady.
Of course, here we go. We have A 27724LT S82122N, B 27722LT S82122S, C 27722LT S82012N, D 27724LT S82.102C. A 47-year-old patient was previously treated with external fixation for a type 3A left lateral condyle tibial fracture. There is now non-union of the left proximal tibia, and he is admitted for open reduction of tibia with bone grafting. Approximately 30 grams of cancellous bone was harvested from the iliac crest. The fracture site was exposed, and the area of non-union was osteotomized, cleansed, and repositioned. Intrafragmentary compression was applied with 3 screws. The harvested bone graft was packed into the fracture site. What CPT and ICD-10-CM codes are reported? And you have 2.5 minutes, coders. And that's time, coders.
Thank you so much, Miss Sarah. I see you guys rocking and rolling in the chat. Yes, yes, yes. A lot of great coding, a lot of great coding. All right, so let's take a look at what we have, coders. All right, you know where we're going to start. We're going to start with some key words. 47-year-old, previously treated with external fixation for type 2-3A, left lateral condyle tibial fracture, non-union of the left proximal tibia, open reduction, tibia, bone grafting, 30 grams of cancellous bone harvested from the iliac crest, fracture site exposed, osteotomized, cleaned, repositioned, intrafragmentary compression, and 3 screws. We have harvested bone graft packed into the fracture site, and your answer is A. All right, so let's take a look at how we got there. There's a lot going on with it. We pretty much highlighted pretty much the whole thing. All of it was important. Here we go. Let's take a look. So we have 27720, 27722, and 24. So let's take a look. We have non-union. of the left proximal tibia. Okay, so, and then we have the open reduction of the tibia with bone grafting, harvested iliac crest. Okay, now harvested bone graft. All right, so we have repair of non-union, and we already see that there, non-union. And so we know that, okay, we're getting close here. Tibia. All right, there we go. Tibia. We're in the right place there. Sliding graft. No mention of a sliding graft. Okay, we were doing okay till they pop that in there. So again, this common language, that's good, but this particular dependent, that won't work. So the 27722 right there, we're going to take that away. All right, so that's no good. So let's take a look at its cousin here, 27724. All right, so we have for that one the 27722. That's gone again because look, there we go. So anytime you can get a 2 for 1, then hey, we're going to take it. We're going to call it a BOGO. We got one and we got one for free. Okay, so both of these are gone. All right. Now we're going to take a look at the 27724. All right, so everything is the same here, but here we have these two deciding factors. Okay, so this is the time we know that the 27724, the complete code is repair of non-union tibia with iliac or other autograft. Okay, so it includes obtaining the graft, and all of this happened, and it is indeed an autograft. Okay, we know it's an autograft because it was harvested from the iliac crest of the patient. If you're asking, how do you know it's an autograft? The autograft, you know, is coming from the patient themselves, and this was harvested from the iliac crest of this patient. And so this code, it grabs it all. It addressed the non-union. In fact, it is the tibia, and then we have the iliac autograft. Okay, and it also includes obtaining that graft. So now let's break the tie with this particular code that we've got to grab, that ICD-10 CM book. Okay, and the idea when you are on this exam is, again, like Miss Tracy said, only when you need to break the tie. Other than that, stay in your CPT manual. Okay, that will help you to drive to getting to the right answer. So hey, it got us down to 2. So going to take a look here. All right, for S82102C. All right, so we're going to go up to this boss of S82.1. It is fracture of the upper end of the tibia, but we need to come down to here, S82.10. We need to go a little further. We know that by the red boxes. So we land at S82.102. It's unspecified fracture of the upper end of the left tibia. It is indeed specified where we should be. Okay, so that one's gonna be off because it is specified. Okay, so we're gonna take a look at the S82. We're at the boss code, so we come down here to S82.12, fracture of the lateral condyle. Okay, so whenever you see unspecified, it's saying tibia, but it's not specific. Well, it's very specific. It's telling us it's the lateral condyle of the tibia. Okay, so we know we're in the right spot there. We need to come on down. Again, you remember our basics. We remember that red box. Okay, so we're at S82.122, displaced fracture of the lateral condyle of the left tibia.
Thank you for watching an AMCI exclusive presentation.
We have the lateral condyle tibial fracture, but we see that 7th character is needed. We only have 6. You see, we didn't bother with it with here. No need in coding on to the 7th character. We already know we're not in the right place. You know you're not in the right place when you get here because it is specific. So let's take a look at that 7th character. Okay, so we have an N here, and an N is for a subsequent encounter for an open fracture type 3A, 3B, or 3C with non-union. Hey, that addresses it. Okay, so how do we know that it's a subsequent encounter? Because they were previously treated. Okay, previously treated. That's what tells it. Okay, another way you can break the tie before you even start looking here, I personally, a lot of times I would just hit right here to this 7th character. what is it? And I would ask myself, what's the difference between N and C? As soon as I see C, initial encounter, boom, that's not initial encounter. It's telling us it was previously treated. So that's already gone. So it's out of there. Bam. With the S, a sequela, it's not a sequela. This patient is coming in because they were previously treated. Okay. And so it's a subsequent encounter. But if you're still stuck with that one, we were able to knock it off just based on that particular code here. But definitely this one, I would go straight to there and see what can I get off confidently. You know it's not an initial encounter. Even if you're kind of teetering with, sequela, I don't know, but you know this right here, it is not initial encounter. So boom, you could get rid of that. And you had already gotten rid of that. And then there you go. We already know. Look how specific that is. And so that indeed is your code from your ICD-10 CM book. And so A is going to be your answer. All right. So how are we feeling, coders? How are we feeling? We unpacked a lot with that one. We unpacked a lot with that one. All right. Good, good, good.
Thank you for watching an AMCI exclusive presentation in partnership with AAPC. Until next time.